we have guidelines that was released recently from European Society of the Intensive Care about ARDS guidelines. And I would like to start first to say thank you for Matt and Vaz and Zoe for giving me this chance. And it's very interesting actually to look at these guidelines, especially how they figure out these guidelines and how they looked at the evidence for every recommendation that was there. So I'm going to start with the methods. We may find out that most of these recommendations we follow in our practice. But as I said, it's not just about the recommendation itself, it's also about how they made these recommendations. Last guidelines was released in 2017. And these new guidelines has been made in the context of post experience of pandemic. So it's quite enriched, and they have a lot of evidence coming from the experts because a lot of studies that was made about COVID pandemic area is not yet, the results are not yet released. So what they have done, they formulated 3 domains: definition, phenotyping, and respiratory support strategies. They also have divided some to 9 subdomains, including definition as one, phenotyping as one, and the recommendations about the respiratory support strategies was divided to high flow nasal cannula, oxygen, non-invasive ventilation, tidal volume, PEEP, lung recruitment maneuvers, prone position, neuromuscular blockade, and extracorporeal life support, which is ECMO. They nominated 3 chairpersons and 1 methodologist. And for each domain, they had a domain chair, and they made this international panel to look at all the evidence that was available by looking for all the evidence that was available and looking to 3 points. First, certainty of the evidence, and the grade of the methodology, and how is it going with the expert opinion or not. So they looked at all the literature and the meta-analysis, and they looked at all the available research studies in PubMed that was PubMed cited. So quite a lot of effort was done for this guidelines. And first was about the ARDS definition, which we go with the traditional definition that we know about, which includes timing, which is 1 week of known clinical insult or new worsening symptoms, and chest imaging, which includes bilateral infiltration, and the origin of the edema, it needs to be non-cardiological pulmonary edema. And they have divided the oxygenation to mild, moderate, and severe according to the BF ratio. Here in the Berlin guidelines, they looked at the BO2, which is millimeter mercury. We use kilopascal here in the UK. So this was the definition that we were going with. They looked at the definition, they looked at the studies that has discussed this definition, and they made some recommendation. So recommendations in general was to widen the definition. And also another recommendations and various reasons for widening this definition. So for example, the old definition was to include mainly the intubated patients, but now, because the high flow nasal cannula has been used more frequently with acute respiratory hypoxemic patients, they would like to widen this definition to include the patients that was diagnosed with ARDS, but still in high flow nasal oxygen. Also, they suggested using SpO2 ratio instead of PA2 ratio, as far as we have a lot of patients on high flow nasal oxygen. Also, they criticized using the chest X-ray as a part of this evidence as a criteria of the ARDS, because the argument is that it's not reliable. The interpretation of chest X-rays are not reliable to be used as one of these criteria. And despite making these recommendations, there was some arguments about it. So the opponents of this recommendation, they had the feeling that this may dilute the severity of illness of ARDS. So ARDS patients, they are usually very sick patients, very hypoxemic, refractory to the usual maneuvers and for treating hypoxia, and also the ARDS phenotype that we will come to was made to label these patients as very sick patients. So this was one of the arguments. Also, another argument regarding using SpO2 FiO2 ratio instead of PaO2 which showed that SpO2, the saturation, sometimes is not accurate, especially with the patients who are shocked, and also sometimes the patients are over-treated to have sat more than 97%. So it depends on the clinician who's treating the patients, and it depends on the interventions that is given to the patient. And finally, they found that recent randomized controlled trial failed to demonstrate any improvement in chest X-ray interpretation even after training. So this was the recommendations and the arguments. And also they suggested that these criteria needs to be established for a bit of time before making this diagnosis. If these criteria are met in a minimal time in a certain patient, this doesn't mean that this patient is an ARDS patient. It needs to be quite sustained criteria before making the diagnosis of ARDS in any patient. So they discussed a minimum time frame for which patient must continue to meet criteria for ARDS, but also they haven't identified a certain period about that. So still much work remains to be done to harmonize clinically visible definition about ARDS. Until this point, the final recommendation from the panel that we still use the term of acute hypoxemic respiratory failure as a broad umbrella for refractory hypoxemic patients instead of ARDS. So I'm going to go to the next domain, which is phenotypes and subphenotypes. But at the same point, this domain is quite theoretical and it doesn't reflect much to our practice. So I'm going to go through it because I committed to go through all the guidelines that they have released. But you may find it quite theoretical instead. So what they have tried to do in this domain, to divide the ARDS patients in various subphenotypes, so they can individualize the treatment for every, or divide the treatment for every, tailor the treatment for every subphenotype of ARDS. We'll see if this does work or not, what's the subphenotype definition, which subphenotypes they have identified, and the next domain. So the phenotype here, they defined it as clinically observable set of traits resulting from an interaction of genotype and environmental exposure, which this definition can be applied to ARDS. Subphenotype is a distinct group that can be reliably discriminated from other subgroups based on a set or pattern of observable, measurable properties. We'll see if we can apply this for ARDS or not. So they said that accurate classification of the subphenotype is critical, as exemplified by the results of LIFT trial. I'm going to go through the LIFT trial in the next slide. So in general, overall, there was no benefit to personalized treatment strategy. However, the misclassification of subphenotype resulting in misaligned treatment strategies was common. And this was a result from left trial. Let's see how they have done with the left trial. So in the left trial, they divided the patients to two groups. Group of them is ARDS patient, regardless the cause, regardless the pattern of the disease. Any patient who is meeting the criteria of ARDS is labeled as ARDS patient in the control group. The other group was the group with personalized mechanical ventilation strategy. They divided them into two groups, focal ARDS and diffuse ARDS. So in the diffuse ARDS, they made ventilation strategy 4 to 6 ml per kg. And in the focal ARDS, they made ventilation strategy of 8 ml per kg. And they have found that personalization of mechanical ventilation didn't decrease mortality in patients with ARDS. But surprisingly and interestingly, this is possibly because the misclassification of 21% patients. So ventilator strategy misaligned with lung morphology substantially increases mortality. So there is no difference, but at the same time, they have found that there was significant misclassification of the patients in this trial. So it's quite difficult to identify the patients from the first instance, and also for the evidence that we have till now, including this bias in the trial, it doesn't make any difference in the mortality. So the question is, does subphenotyping of the ARDS patients will make a difference to the ARDS management patients? So here they looked at two studies. Both of these two studies has looked at the effect of statins in the ARDS patients. So in a secondary, one of them is the HARP trial. Sorry, Vaz, you're saying something. I'm just trying to.
No, don't worry. Sorry to interrupt. That's why I put it on the chat. We can talk about it later. Carry on. Sorry.
Yeah. In a secondary analysis of the HARP2 trial, patients with hyperinflammatory subphenotype benefit from the simvastatin. But when they looked at the SALES trial, there was no heterogeneity of treatment effect was identified for the hypoinflammatory and hyperinflammatory subphenotype when they treated with rosuvastatin, which means that there is no difference if it is hypo or hyperinflammatory according to the SALES trial in the response to treatment with rosuvastatin. So it doesn't make change in, it doesn't alter the management of the patients, but in the next slide, they have found that it can alter, it can alter the prognosis. So when they looked at the prognosis, yes, hyperinflammatory ARDS that was identified by the plasma proteins has higher mortality. More radiological involvement of the ARDS disease, they have higher mortality rather than in non-focal rather than in focal ARDS. The recruitable patients, they have higher mortality than the non-recruitable patients. And finally, higher mortality if the patient has multi-organ failure, obviously, than the non-organ failure. And so when you look at all these parameters, the subphenotyping will affect the prognosis, and it's not going to alter the management, but at the same time, most of the trials that we have, they have some sort of bias. The trials that we have about the effect of subphenotyping on the management. But at least we have now seen that it has an effect in the patient outcome and the prognosis. This was very quite theoretical, and we are going to move now to something more interesting about the treatment strategies for ARDS patients. So first was discussion about high flow nasal oxygen. The question was, in non-mechanically ventilated patients they used the term of acute hypoxemic respiratory failure, which we mean, there's difference obviously, but we mean ARDS patients. Does it reduce mortality or not? I was going to enroll Bull in this presentation just in the last minute, but it didn't work. So, and unfortunately, I can see you also, so I'll just go through the answer. They have found that it doesn't reduce the mortality, but at the same time, it will reduce the risk of the intubation. So they recommended using the non-mechanically ventilated patients with ARDS, because this will reduce the risk of intubation if it's compared to the conventional oxygen therapy. And it's strong recommendation with moderate level of evidence in favor. They haven't found any, or they haven't made any recommendation about with or against the use of high flow nasal oxygen in aim of to reduce the mortality only. Number 4 is CPAP. Question, does it in non-mechanically ventilated patients with acute hypoxemic respiratory failure and not due to the other reasons like cardiogenic pulmonary edema or obesity hypoventilation or COPD, does CPAP as compared to conventional oxygen therapy will reduce the mortality or risk of the intubation? So they are not able to make a recommendation about CPAP to that it will reduce the mortality again, the same as that was recommended for high flow nasal oxygen, but still CPAP can save some patients from being intubated. And next question, because we sometimes have some masks, including the mask of like full face mask or the helmet mask. Does it make any difference? So they are also unable to make a recommendation for or against the use of helmet interface for CPAP to prevent intubation or reduce mortality. There is no difference. I would say I use whatever is will make the patient compliant to CPAP or whatever will make it easier for the patient. So no recommendation. Number 5, low tidal volume strategy. Does low tidal volume ventilation alone, compared with more traditional approaches to ventilation strategy, decrease the mortality? And I believe most of us know the answer. So it's strongly recommended to go with low tidal volume strategy, and this will obviously reduce the mortality in patients with ARDS, not due to COVID patients, not due to COVID, and this also applies to the COVID patient. I forgot to mention that it also applies to the COVID patients, and the strong recommendation and the evidence is high. Number 6, PEEP and recruitment maneuvers. So the first is about PEEP. And we have different ways to titrate PEEP, and there are 2 ways we can titrate PEEP. Some of the centers or institutes will just go with PEEP-FI to tables where they just follow whatever FI2, they will increase the PEEP. If the FI2 goes up, they will increase the PEEP. If it goes down, they will decrease the PEEP. So first question, and the other way is to do respiratory mechanics, lung mechanics, and with different ways to find out what's the best PEEP for the patients. So the first question is, with patients with ARDS, with invasive mechanical ventilation, does routine PEEP titration using higher PEEP FiO2 strategy compared to lower PEEP FiO2 strategy, does it reduce the mortality? And also, they didn't recommend anything about this. So there is no evidence that can make any favor for any of these strategies, higher PEEP or lower PEEP with FiO2, higher PEEP with less FiO2 or higher FiO2 with less PEEP. No recommendations, and the evidence is not in any favor of any of these two strategies. Second question, the same point also. Does routine PEEP titration, is it better to go with the respiratory mechanics or PEEP titration with PEEP FiO2 tables? And also, they haven't made any recommendations with or against PEEP titration according to the respiratory mechanics or according to PEEP FiO2 tables to reduce mortality in patients with ARDS. So you use whatever you can or whatever you are comfortable with, and whatever you are confident with, and whatever is in the usual practice in the center that you are using, because there is no recommendation about in favor of any of these strategies. And this also applies for patients from ARDS for COVID. So the next question is about the recruitment maneuvers. Some of the literatures suggested using prolonged higher pressure recruitment maneuvers, like some of the literature suggested that patients with PEEP of 40 for 20 seconds or 30 seconds can give a better recruitment to the patients and may improve the mortality, but the recommendation was clearly against using the recruitment maneuvers for any pressure that's more than 35 centimeter water. And it was found clearly that it will reduce the mortality in ARDS patients. The last recommendation in this domain, where they were saying, does routine use of brief higher pressure recruitment maneuver compared to no use of brief high pressure recruitment maneuver reduce mortality? And this was against, sorry, this just was repeating of the last recommendation. 7, prone position. First, does prone position reduce the mortality or not? And I believe from our practice, and most of us know about this, so there is a clear recommendation that using prone position compared to supine position will reduce the mortality. And the next question is, when should we prone the patients? When should prone position started to reduce the mortality? So according to these guidelines, according to the panel, they recommended starting pruning position in patients with ARDS receiving invasive mechanical ventilation just early after the intubation and after a period of stabilization during which low tidal volume is applied and PEEP adjusted. So if the patient is refractory hypoxemic and intubated after a period of stabilization, and during this period of stabilization, the low tidal volume strategy is followed, then it will be very useful and cause significant reduction in the mortality to give this patient to keep the patient in prone position. And the question, which I think was brought to the attention during the pandemic, about non-intubated patients, acute hypoxemic respiratory failure. Does it help with the awake patients or not? Sorry. So they suggested that awake proning position compared to the supine position for non-intubated patients with COVID-19 acute hypoxemic respiratory failure will reduce the intubation risk. And this looks like as most of the interventions that we use before the intubation. And they cannot make any recommendation about reduction of the mortality also. So it looks like that most of the intervention that we can do, the panel has found that it will reduce the risk of the intubation, but most likely it's not going to make any difference in the mortality, or they are not able to make any recommendation about it. And this can be applied to the awake proning position, high flow nasal oxygen, and CPAP. 8, about neuromuscular block. So the question is, do we use the neuromuscular blockers routinely or not? Does it help with the ARDS patients or not? And with the recommendations was clearly against routine use of the neuromuscular blocker for the ARDS patients, and it clearly can reduce the mortality between them. That's very clear for ARDS that's not due to COVID-19, but they are not able, due to lack of the evidence, to make any recommendation about using of neuromuscular blockers with ARDS due to COVID-19. And finally is ECMO. So does it make difference to the ARDS patients? And I think this question was released because it wasn't discussed in the guidelines that was released in 2017. So they recommended, if the patient is meeting the criteria that's in the EOLIA trial, that I'm going to go through these criteria now, to be treated with extracorporeal membrane oxygenation support if needed in an ECMO center. And however, they mentioned this in the recommendation. This was based, so they applied the same recommendation also for COVID-19 patient, but this is based on the recommendation from for the non-ARDS patients. Still, there is low evidence, a strong recommendation, but low evidence in favor for indirectness, because it was mainly these trials, AOLIA trial and CESAR trial, both of them, they were made on non-ARDS patients, and that's why they recommended it, but they kept the level of evidence as low because it was about another category of patients. So they looked at mainly 2 randomized controlled trials. One of them is EOLIA trial, and the other is CESAR trial, which was done in Glenfield Hospital. They have taken the inclusion criteria of EOLIA trial, which is PF ratio less than 50 for more than 3 hours, or less than 80, and this applied to millimeter mercury, more than 6 hours, pH less than 7.25, or PCO2 more than 60 millimeter mercury for more than 6 hours. They suggested that these criteria can be an inclusion criteria or can be eligibility criteria for COVID patients. But obviously in Glenfield Hospital, we look at another different things. It's not just about the numbers, it's not just about the hypoxia as a single indication for ECMO. And they have found from looking at these 2 trials that the 60-day mortality in patients receiving VV ECMO compared to conventional mechanical ventilation, the protective effect was consistent across the 90 days mortality outcomes as well as composite outcome mortality. So no randomized controlled trials for COVID-19 patients, and the evidence for ECMO in COVID-19, as I mentioned before, was assessed as weak in favor because it was downgraded because of the indirectness of the available randomized controlled trials. And they also mentioned that a network of ECMO centers with expertise in the technique is likely to be required to make the ECMO effective. So the centralization of the service is quite important for the exposure of the ECMO team to help with providing the best service for the patients requiring extracorporeal membrane oxygenation support. There is another extracorporeal kind of support, which is the extracorporeal carbon dioxide removal. This kind of support is quite widely used in Europe. I haven't seen it in the UK, and because of the guidelines of the European Society, they looked if it's going to make any difference in the mortality or not. And basically, it's the same as ECMO, but with less flow, less blood flow, and it's mainly effective in clearing CO2 instead of oxygenating the blood. And it was clearly that they recommended against using of extracorporeal carbon dioxide removal for ARDS not due to COVID. So, and also the same recommendation can be applied for COVID patients. So this was all the recommendations from the European Society, and there is a comparison between the guidelines that was released in 2017 and 2013. So regarding the definition, there is not much difference because they already didn't give any recommendations in 2017 guidelines, and the same can apply for the phenotypes recommendations and high flow nasal oxygen and non-invasive ventilation. All this was not discussed in 2017 guidelines. They agree with the tidal volume recommendations in 2017, and they modified of the PEEP recommendations. So in 2017, it was suggested to give higher PEEP FI2 strategy. In 2023, they have no recommendation in favor of any strategies. 2017, they suggested the recruitment maneuver. In 2023, that this is one of the clear difference between 2017 and 2023, that they are against prolonged recruitment maneuvers, and this will clearly increase the mortality and risks. They have not discussed the oscillatory ventilation because in 2023, because there was no further evidence and there was no further trials after the evidence that was provided for 2017 guidelines, which was clearly against the using of oscillatory ventilations in adults. They are in agreement about the prone position recommendations. Also in 2017, they haven't discussed any recommendations about using neuromuscular blockers. So that's something that was brought new to the 2023 guidelines. In 2017, they asked for more evidence, but in 2023, they suggested that ECMO will improve the survival of ECMO patients, and extracorporeal CO2 removal. It wasn't discussed in 2017. In 2023, they said it's against, or it will increase the mortality actually. So they are against using it. We don't use this this type of support actually anyway in the NHS. So So looking at these guidelines, some of our practice will go with these guidelines, but at the same point, I believe we may find out that some of these recommendations may alter our practice. I'm not sure how everyone will take it in his practice and how much you are already going in line with these guidelines and how much you will need to take from these recommendations. Sorry, I haven't made a lot of interaction with you because I can't see you if I want to share this screen, but I'm happy for any questions.
Hi, Mohammed. Thank you very much for this presentation. It was amazing. Just a couple of questions. So regarding the neuromuscular blocking agents, so the recommendations against them in the 2023?
Yeah, it's against them, but against as a routine use. Like I worked in a center where they paralyze all the patients. They give them volume control mode. They paralyze all of them, and some of them will. So they will give you a good synchrony with the ventilator, but they have strong evidence that this will give them critical illness myopathy. This will increase their mortality, 90-day mortality. So they are against using them as a routine use, and I believe as an infusion. But I believe this recommendation doesn't apply to like induction for intubation or things.
Okay, it's just because sometimes if we struggle with the synchronization with the mechanical ventilation, it's like not last resort, but we sometimes use it as infusion for patients with ARDS. So is this going to be a change of our practice, or what do you think?
Well, from my understanding from the guidelines, we should keep it away as much as possible, the neuromuscular blockade. And I believe we have now different ventilation strategies that we can try with the patients, so we can avoid routine infusion of neuromuscular blockade. And this is my understanding. For my practice, I don't use them currently. But if I was working in a center that I have worked before where they paralyze all the patients with ARDS with beep higher than 12, or 12 or above, so I will change my practice definitely.
Okay. The other question is regarding APRV. So they mentioned the high PEEP in recruitment maneuver, which is more than 40 for 30 seconds or something like that. But they didn't mention anything about APRV. So are we still using it?
No, they haven't looked at APRV specifically, but what they are trying to go against is, or what they recommended clearly that they are against is the recruitment maneuvers where we give PEEP more than 35 for a bit of time. So some of the literature recommended using like switching the patient to CPAP and putting PEEP of 35 for 40 or 40 for 20 seconds or 20 for 40 seconds and see how he goes, or if he, because some of the literature recommended this as a temporary recruitment maneuver. This is what they are against with. So what comes to my attention that any pressure more than 35 or clearly 30, regardless if it's plateau pressure, regardless if it's sustained recruitment maneuver pressure, it shouldn't be applied to the ARDS patients and will clearly increase the mortality.
Okay, thank you. Thank you very much.
No problem.
Hi, well, thanks very much. That was great. No, I just put a link on the chat there about phenotyping. That so this is data that came out after the recommendations were published. So phenotyping is very important. It is theoretical, but actually isn't. So using latent class analysis, you can actually phenotype ARDS patients before they develop full-blown ARDS, whatever that means, because the definition is not really specific to characterize these patients. Which is the case with any syndrome that you're trying to define. So so this data relate to hyper and non-hyperinflammatory ARDS, where you can actually apply precision medicine principles and kind of individualized treatment. So you by using biomarkers or class variables, you can actually identify those, for instance, who are likely to be steroid responsive, i.e. give early steroids in the ED, for example. But clearly, the more data needed. The point I was trying to make is that yes, when they generate the guideline following critical appraisal of the literature, this data was not out. So there's a lot of data in phenotyping, not just the ARDS, but other systems as well, RV injury and so on. So
but I have the right to say that even with the trials that made no difference between the individualized or tailored ventilation strategies and non-tailored live trial, they mentioned that there was a lot of bias regarding the classification and dividing the patients. So they are very clear that the evidence is biased with a lot of the evidence that they suggested that it shouldn't change the outcome. It was biased with a lot of misclassification of the patients.
So no, I do not disagree. But yes, so you can use phenotyping to enrich clinical trials, which is probably the future of research in intensive care. So you use predictive and prognostic enrichment by phenotyping patients. So, for instance, you mentioned ventilation strategies. So you can recruit patients based on hypoxemic patients, for example, based on their response to PEEP. And then you can recruit PEEP responders and PEEP non-responders. And then you're not biased, and you actually individualize therapy, and your results may be more reliable if you do it this way. We haven't got that much data on predictive enrichment randomized controlled trials, but this is the future, if that answers your question.
Yeah. I totally agree with you. What I'm saying is just that we can use the phenotyping for the prognostication, and it has clear impact on the prognostication. And for the ventilation strategy, even the recommendation is that's still not clear if it's going to make difference to the treatment. The evidence itself is biased. That's what I'm saying. So still more trials and more research is needed to establish if it's going to make a difference or not.
Yeah, that's quite possible. Yeah. So so that was a great presentation. A lot to talk about. So you mentioned tidal volume and mortality reduction. Do you think that mortality reduction comes from the 6 ml per kilo predicted body weight?
That's why they have said.
No. So there's more data from Iwan calling here actually on that. So the reduced mortality is not due to 6 ml per kilo tidal volume, because if you have a baby ARDS lung and you deliver 6 or 5 ml per kilo tidal volume, and that generates a regional driving pressure of 30, you could potentially kill them with that. So it's the low driving pressure, the regional low driving pressure and mechanical power that confers the mortality benefit, not the low tidal volume. And that is based on further data from the ARMA trial, which I can share in the chat group if you want.
Yeah, maybe I have, sorry, I should receive questions, but I will direct the question for you because you asked me to do this presentation. So
yeah.
I feel that most of the recommendations are quite sensible, so it applies to all the research trials and to our practice also. The only one that I found it quite surprising to me is that there is no difference for titration of PEEP between the respiratory mechanics strategy and the PEEP-FiO2 table. So in my practice, I believed so much in the lung mechanics and establishing the best PEEP for the patient, looking at the flow volume loops and the best tidal volume that can be achieved with different PEEPs and all the lung mechanics parameters. I was just quite surprised that there is no difference in the mortality between both strategies. This is the only one that it could be quite strange to my practice.
So can you hear me?
Yes, I hear you.
Sorry. Yes. So there's many questions there actually. What is high, low, and moderate PEEP? How would you define that?
No, I'm not saying about. I can find that with two ways. So they looked at the two strategies. One of these strategy is PEEP FI2 table. So with FI2 of like 80%, you'll give PEEP of, let's say, 12, regardless of the lung mechanics of the patient. This is what they mean by the PEEP FI2 table strategy. And the other strategy is, as we practice in Glenfield, and as I believe this should be the good practice, or I believe that, is to look at the lung mechanics and adjust the PEEP for the patients as possible.
No, I agree. And that makes physiological sense. But there's no data on what's the best way to identify the optimal PEEP, because we don't know what optimal PEEP means. You start with PEEP of 5, that's a random number. Why 5 and not 7? So the point I'm trying to make is that before you titrate, you increase or decrease PEEP, or you decide that this is the best PEEP for this patient, i.e. individualize PEEP, you need to assess recruitability. So how do you assess recruitability? You use, I use recruitment inflation ratio, because you cannot randomly increase the PEEP and then look at SpO2 or PF and assume that this is a PEEP responder, because you may recruit collapsed alveoli and over-distend healthy alveoli, i.e. cause damage. So, I mean, clearly there's a lot of work in that field, but that's why there's no right or wrong, because we don't know what moderate PEEP is, what low PEEP is, what optimal PEEP is, and how you optimize PEEP. So I use driving pressure to optimize PEEP and identify a range where an increase in PEEP does not cause an increase in driving pressure more than 2 to 3 centimeters. And that brings me to another interesting part of the guideline, or gap in the guideline, which is the pulmonary circulation, which they did not include. So they didn't look at RV protective strategies or RV protection, because patients with ARDS do not die of hypoxemia, they die of multiple organ dysfunction. And RV injury or RV dysfunction or RV failure, whatever you want to call it, is an independent predictor of mortality. So there was a meeting with those who actually wrote the guideline, and Giacomo Grasselli led on that. And when we asked this question, they said, yes, that's a big gap, but we cannot discuss everything, which is fair enough. So don't forget the lung heart crosstalk. Okay, so your strategy needs to be both lung protective and RV protective. But what is RV protective? That's another presentation. So we wrote an editorial on that. If you're interested, I can put it in the chat as well, just discussing that gap, not criticizing the guideline, just kind of highlighting the need to protect the heart as well as the lung in ARDS.
Okay.
But well done, that was great.
Thank you. It was a very talkative speech. I like to include images and charts, but there was no chance to put them. So I hope it's not boring.
That was very, very useful. Thank you very much.
Thank you.